Good evening, or good morning, or good afternoon, everyone. Thank you so much for joining today. This is the part one of a two-part webinar series on cornea surgery. Okay, before we start, we wanted to orientate you on the webinar on how you can actually ask questions as well as download handouts. So on your right, you are able to see a Q&A tab. Feel free to type in your questions throughout the whole session, and all of the questions will be published during the Q&A session at the end of this talk. Okay, we also have a handout and a poll whereby you will be able to see the polls that are going live as well as download the handouts that are available. Okay. So just a background on why we are doing this talk. So when we did a very quick survey on the Southeast Asia region, we kind of realized that a lot of cornea surgeons in the region still are doing the PK procedure, and there is not a lot of cornea surgeons that are using the intraoperative OCT for cornea surgery. All right, so now under the polls, we have started some questions. We would invite you to actually share some of your background and expertise so that the speaker can actually start to understand the attendees that are in the room today and customize the presentation for the next webinar. All right. Okay, so today's session is on DMEK and complicated DSAEK surgery. Our speaker today will actually cover this items on the agenda, and it will be a 1 hour talk consisting of a 45 minutes talk and 15 minutes question and answer session. A bit about our speaker today. So Professor Jod Mehta is the Distinguished Professor at Duke-NUS and Singapore National Eye Centre. He is the head of the Corneal Service Singapore National Eye Centre, head of the Tissue Engineering and Cell Therapy Group, and he is also the named Professor of Clinical Innovation, Director of Education at SingHealth Transplant, and Deputy Executive Director at Singapore Eye Research Institute. Prof. Jod Mehta has actually published more than 390 peer-reviewed papers and 20 book chapters. His work is focused on corneal transplantation, femtosecond laser technology, corneal imaging, corneal infections, corneal refractive surgery, keratoprosthesis surgery, and corneal genetics. Okay, so without further ado, I will then hand the stage over to Professor Jod. Okay, so Professor Jod, handing the stage over to you. You can start sharing your screen now.
Okay, great. Thank you, Phoebe.
Okay.
So I'm just going to the screen.
Yeah.
Okay, so you can see my first screen picture?
Yes, so
okay.
The stage will be passed over to you now.
Great. Okay. Yep. So good morning, good afternoon, good evening, everybody. So thank you for attending this live webinar. So we're going to be talking about DMEK and some complicated DSAEK surgery and surgical management, and really focusing on the role of intraoperative OCT in these surgical procedures. These are my financial disclosures. They pertain to some of the instrumentation that you will basically be seeing on how to do the surgery. So I'm just going to give you an overview of this first session. As Phoebe said, this is one of two parts, and today we're really going to focus on EK surgery, so primarily DMEK and DSAEK. Some tips for basically improving your outcomes, basically following the surgery itself, how we think that leveraging on modern technology such as intraoperative OCT can help with that, and some of the key advantages of intraoperative OCT for these surgical procedures that can help you basically reduce the learning curve. And we'll go through some examples, and I'll talk about this in a little bit more detail. So you're all aware of the current sort of state of play with respect to corneal endothelial surgery. And obviously penetrating keratoplasty was the most common procedure performed for almost 90 years. And more recently, over the last 2 decades, we've seen a massive increase in the way we perform basically endothelial replacement in the form of either DSAEK or basically DMEK surgery. Okay, DSAEK obviously is a similar form of DSAEK surgery itself. It's just that the donor is prepared with a manual dissection as opposed to an automated section. And this schematic really here shows the big difference between DSAEK and basically DMEK. With DSAEK, you have a bit of stromal tissue basically attached to the desmoid membrane and then the endothelium, while with DMEK, it's just basically desmoid membrane and purely and the endothelial basically cells. And you can see the advantages of these procedures where you're selectively just changing the endothelial cell or the diseased tissue at the back of the cornea, as opposed to full thickness penetrating keratoplasty, which you can see on the left-hand side. And this has been reflected in our surgical workload. If you look on the left-hand side over here, you will see data from the Eye Bank Association of America from 2018. On the right-hand side, you'll see data from the Singapore Corneal Transplant Database. In the red line over here, you will see that in 2011, EK became the dominant transplant procedure in the United States. EK became the dominant transplant procedure in the United States. PK is basically second in blue, and DALK or ALK is basically down over here in green. In Singapore, it's a slightly different story where EK became the dominant procedure back in 2008, 2009. You can see the curve rising up over here. DALK is our second dominant procedure that basically we do, and PK is basically relegated down into third place. So I think we have to be aware that the face of corneal transplantation has changed dramatically over the last 12 years with respect to our field, and PK is no longer the procedure of choice, certainly no longer the procedure of choice for endothelial transplantation. I mean, of course, we still have to do some PK cases, but EK and DALK have become the dominant procedures. And if you look from my own series, I roughly do about 86% of lamella, only about 14% penetrating keratoplasty. And these are the years basically that we call the inflection points, where the procedures became the dominant procedure. And you can see that after those points, those procedures have gone on to dominate the way we basically perform surgery itself. So why do we need to even change? What is the effect of the outcome? So if you look at this Kaplan-Meier survival curve, what it shows you is the outcomes of following standard penetrating keratoplasty, and it's grouped every basically 5 years. So you can see the blue line over here is between 91 and 95, the green line between 96 and 2000, and so on up to basically 2006 and 2009. And what you can see is that as the Kaplan-Meier survival curves are grown, actually most of these curves are exactly the same. Okay, so what that means is that if you had a transplant in 1992 or you had a transplant in 2007, your outcome is exactly the same. It doesn't matter. We may have better microscopes, we have better viscoelastic, we may be using steroids better. It actually really doesn't matter. Your outcome is exactly the same. Okay, so it doesn't, the procedure itself hasn't changed, even though we may have improved medication, surgically maybe better sutures over that basically 15 to 18 year period. And the analogy I can give you with other technology, this is a mobile phone from the early 90s, and this is obviously a mobile phone that you'll all basically be familiar with. And you can see how much technology has changed, but in fact, the transplantation with respect to penetrating keratoplasty hasn't changed basically over that time period. And I'm sure none of you would want me to swap your iPhones that you have now with a phone like this itself, because it'll be basically useless for you to use. However, if we look at the outcomes from survival curves of these new selective lamellar transplantations, you can see over here EK in basically green, in red, ALK or anterior lamellar keratoplasty in green, and penetrating keratoplasty is what I showed you on the previous slide over here in blue. You can see here by changing the way or the type of surgery that you're basically doing, you can improve your long-term outcomes. Okay, and this is basically showing up to about 10 years. We have data now going up to basically 20 years now, since we've basically been shifting to doing more lamellar keratoplasty over the last 22 years at SNEC itself. And it's by changing the procedure, you're going to basically improve your long-term outcomes. And these two graphs really illustrate the differences in basically your outcome itself. So when we look at endothelial keratoplasty in particular, what is the big differences between penetrating keratoplasty and endothelial keratoplasty? So on the left-hand side, you'll all be familiar with this typical penetrating keratoplasty graph over here with the standard basically sutures around the edge. On the right-hand side, this is basically a DSAEK graph as well. Well, the first thing is, of course, the incision is much smaller. So this is much more similar to what we like closed eye surgery. And you can think of an analogy almost comparing an extracapsular extraction surgery compared to basically small incision phaco emulsification. So you see over here, we have the large incision all the way around over here, while here with this EK technique over here for DSAEK, you have just a small 4.5 millimeter incision over here itself. So you get greater wound strength. So the eye is tectonically stronger than with a basically full thickness penetrating keratoplasty. There's minimal number of sutures, so you have no issues on the ocular surface with respect to ocular surface disturbance. And of course, because you're not cutting the nerves basically in the cornea, there's no neurotrophic state like you have with penetrating keratoplasty. Because there are no sutures, there's a reduction in regular and irregular astigmatism. So people like the quality of the vision they achieve with basically EK surgery because there's less issues with basically refractive error. And this likewise leads them to a faster basically faster visual rehabilitation. And subsequently, it's been shown in the literature over the years that there's a reduced risk of rejection. Generally, our penetrating keratoplasty rejection rate is in the region of about 10 to 12%, basically a 1 year. And with EK surgery, depending on what EK surgery you do, but with DSAEK, it's about basically 3.5% for us. With DMEK, it's less than basically 1% itself. And generally speaking, it's relatively easy to change these transplants because you just need to open up the previous keyhole incision, take the graft out, and then put the graft basically in again. And we'll be showing you a case of that we did recently, where we changed the DSAEK for basically a DMEK itself. So this is basically the steps of the DSAEK procedure itself. So the first bit is basically the recipient preparation. Now, basically, I prefer to do a scleral tunnel. This is normally basically 4.5 millimeters in length. And normally we'll make a small porotomy around the edge of the area of the sclera where we're going to basically do the marking. Okay, so just do a marking of the sclera. I'm just measuring the size of the graft that's basically going to be used. And normally we'll basically do a small, basically, limbal tunnel, and then we will basically open this up using basically a crescent knife. Now this is a combined phaco DSAEK procedure. So of course you'll take the lens out basically when you're doing the surgery first, and then continue with the DSAEK procedure itself. The donor preparation is either cut or prepared by using typically an ALTK system. We use basically the Moria system. There are other ones available on the market as well. And what the ALTK system will do is to cut the anterior cap of the donor. So here you can see I'm releasing the anterior cap from basically the posterior lamella, and of course that's the important endothelial cells basically lying there. And ideally, you're trying to cut as thin as tissue as basically possible. Most times now we're trying to cut in the range of less than 100 microns because we know this will basically affect the visual acuity afterwards. The thinner seems to be basically better itself, but you do have to bear in mind that it does require more manipulation inside the anterior chamber when you're doing the surgery itself. And typically, a lot of eye bags now go to basically pre-cut tissue. If you don't have pre-cut tissue, then of course you have to prepare the tissue yourself with an ALTK system. It is of course possible to do this with a manual basically technique where you basically do a thin episode of dissection. Then the next bit of the procedure is basically stripping off the diseased endothelium or the diseased Descemet's membrane and the endothelium. Typically, we like to perform this basically under air. You can see you get very good visualization of basically the Descemet's membrane. You score initially around the outside where you're basically going to do the stripping. Now, the stripping is quite important basically depending on whether you're doing DSAEK or basically DMEK. If you're doing a DSAEK procedure, really the size of the stripping, especially of the guttata, is important that you remove the central area of the guttata over here. So at least the central 4 to 5 millimeters of the Descemet's need to be removed. If there's remaining Descemet's around that area, it doesn't seem to affect the graft adhesion when you basically put the graft inside the eye. The graft will seem to stick. However, with DMEK, you want to basically strip outside the area of basically where the graft is going to go. So typically, if I'm doing a 7.75 DMEK, I will strip basically at 8 millimeters. So I'm stripping about 0.25 or larger than the area of basically my graft. And it's important to do that because if you have any tags there, it will affect the graft adhesion because the graft is basically so thin. So once you've done the stripping, you simply remove the Descemet's membrane basically from the eye, and then you're basically waiting for the donor itself. When you insert the donor, there's several different techniques for basically doing this, and this has evolved over the last sort of 10 to 15 years. I'm just showing you a video, a very old video. This is back from 2006, where we're basically doing a taco fold. This is the first method described in the literature of how to basically do donor insertion. So I'm showing this more for nostalgic reasons, rather than more for education. The next slide will show you more insertion techniques as well. So when you use the forceps to insert the graft, you have to deepen the anterior chamber, and then using an air bubble underneath the graft, you'll see the graft will basically open up, and then you basically will tamponade the graft into position. So the graft basically sticks by having a good air fill inside the anterior chamber. So it's very important that you have full air tamponade basically when you pull the DSAEK graft inside the eye. So it's important to make sure your wounds are basically all closed. So we put a couple of stitches into the scleral incision, take the AC maintainer out. So the AC maintainer can help you basically when you put the graft inside the eye to basically deepen the anterior chamber. And then basically once the wounds are all closed, we typically use air for DSAEK and then you basically give a full anterior chamber fold. And once you can see that golden rings around the edge of the graft, you know you've got a good basically chamber fold. Typically for routine cases, we tamponade a full air fill like this for 8 minutes, and then we basically remove some of the air from the eye to reduce the size of the bubble down to the same size as basically as the graft itself. We've done it, you can see at the bottom over here, there is an inferior PI there itself, so it's safe to leave a bubble inside the eye. Okay, and then you put a contact lens on at the end of the surgery and just finish off closing up the conjunctiva. So as I mentioned, donor insertion has really evolved because it was basically shown that really the donor insertion technique is the bit where the most of the endothelial cells are damaged. And back in 2005, 2007, we were using a tachyfold, like I showed you. We quickly switched to basically the sheath glide because a lot of eyes in Asia have high vitreous pressures because the eyes are basically small. And we found that when you use basically a tachyfold, it was very difficult to open up the glide, the tissue inside the eye itself. But using a sheath glide, which is a simple anterior chamber IOL glide, we used to put it on a bed of basically viscoelastic, and you can see in the video, you can come across the anterior chamber, grab the tissue with a pair of forceps. These are 23 gauge basically forceps. You grab the donor and you simply just pull it inside the anterior chamber, and then you basically pull out the sheath glide. Okay, and there's much less manipulation of the tissue with sheath glide compared to basically the tachyfolding. However, we noticed that basically over that time, of course, the tissue can get damaged because you're putting an 8mm tissue through a 4.5mm incision. And then we basically developed the endoglide back in 2009. The first version was a standard endoglide or the tan endoglide. And the second version that came out in 2011 was the ultra thin endoglide because we wanted to go to basically use thinner tissue. And you can see here when you use the endoglide to basically put it inside the eye, the graft is protected all the way through. You simply hold it into position and you put the air bubbles. So there's a lot less manipulation of the graft itself compared to basically using tachyfolding. So which are the ideal cases you should start with when you're doing basically DSAEK? So typically a Fuchs dystrophy is a good case to basically do, either if they've had previous cataract surgery done in the past and then basically decompensated, or basically a primary Fuchs that's already got fold cells. So this is a very nice case to start with. Other cases that are good to start with are patients with pseudophakic bullous keratopathy, typical with mild to moderate cases. What I mean by that, with a stromal haze is not basically too bad. Remember, obviously, you're not changing the stroma like you do with full thickness penetrating keratoplasty. So if there's too much haze there, it may basically affect the view. Repeat grafts when you get a little bit more confidence, certainly in a previous PKs. Generally, instead of repeating the PK, we prefer to do a DSAEK underneath that. And of course, other forms of endothelial decompensation. In Asia, we see a lot of cases of CMV endotheliitis. So of course, this is one of the higher, more common indications, or PI-induced bullous keratopathy, which is particularly common in Japan as well. So these are some of the typical cases that you will do, but obviously there are other cases that you will be familiar with, eye syndrome and also basically TAS, when the endothelium would decompensate. So these are ideal cases to start off with basically doing DSAEK. So if DSAEK is so good, then why should you basically change to doing DMEK? So if you look at this, this is one patient of mine. This is his right eye on this side over here and the left eye on this side. So we look at the best corrected visual acuity. He had an ultra thin DSAEK done and he did pretty well. I mean, he can see quite well. He's 6.6 in this eye corrected, but it took him about a year to get this visual acuity. His graft is about 75 microns. His graft is about 70 microns thick. And his endothelial cell loss is pretty good. With the endoglide, he got basically 2,600 endothelial cells at 1 year, which is only about 11% cell loss. On the other eye, I told him, don't worry, we'll do basically a DMEK for you, okay, instead. And he said, are you sure? But I'm happy with the procedure. And I said, yeah, I know, but I want you to do it, basically have a DMEK instead, because I think you're going to get recovery much faster. So this guy basically with Fuchs. So you can see on this side, it took him 1 month to get 6.6 vision in this eye. Okay, so he took him a year on the right eye. He got this basically in 1 month. Now his cell loss at 1 year is higher than what I can get basically with the DSAEK, but it's still not so bad with 30% cell loss, 1,800 cells up. Of course, if you ask him which vision he prefers, he does prefer the DSAEK vision because there's less aberration on the posterior surface. It's very difficult to even see this basically on the back of the graft, on the back of the cornea where the actual DMEK tissue is itself. So that's why a lot of people basically switch to basically doing DMEK surgery, because patients do get faster visual rehabilitation, mainly because they get less aberrations basically on the posterior surface of the cornea itself. So they do get better visual acuity, especially over the first 6 to 9 months, even if you compare it to the best ultra-thin results. There are 2 recently randomized controlled trials published in ophthalmology, one from a US group and one from a Dutch group. If you look at the data in detail, the sample size in each of the groups is not so high. The US basically group showed that the visual acuity results were superior with DMEK compared to DSAEK. The European study actually showed that the mean visual acuity between DMEK and DSAEK was the same. But if you start looking at the proportion of patients that actually get better visual acuity, like 2020 or 2025 or 2030, it was higher basically in the DMEK group compared to the DSAEK group. So there is some slight differences from there itself. So there's less aberration on the posterior corneal surface. And one of the key things that I think when you're doing slightly more complicated cases is that there is less rejection. There is slightly variability in the literature when you look at rejection rates of DMEK, but generally speaking, in the same cohort of patients dealing with the same group, you will see there's less rejection with DMEK compared to what you can basically see in DSAEK. But you have to balance this up, but there's probably certainly a higher rate of endothelial cell loss, certainly when you're starting with basic DMEK surgery. Certainly your rebubbling will be high. We use SF6 gas, 20% on all our DMEK cases, and even with that, our rebubbling rates are higher than I get with basically standard DSAEK. Not by much, there is a learning curve, and we'll talk a little bit about some of the advantage over there itself. And basically, so you have to always bear this in mind, that when you're looking at the procedure, which one will be better when you're starting off. And typically those cases that I showed you that you'd start off with DSAEK may be better to actually start, are the ideal cases when you want to translate over to basically DMEK. Those are also the ideal cases to basically start your DMEK journey as well. If you look in the literature and you look at basically direct comparison studies, there's not a lot, but there are basically a few studies in the literature where one eye has had DSAEK and the other eye, or the contralateral eye of the same patient, has had basically DMEK. And what you'll see is that all the studies will show you the visual acuity result in the DMEK eye is basically superior to basically the DSAEK eye. So you do get better visual acuity. The caveat to this is, however, you have to bear in mind that a lot of these DSAEK cases are not what we consider ultra thin. Okay, so they're probably not what we consider the gold standard now for doing basically DSAEK, so under 100 micron grafts. These are probably slightly thicker, and that may explain why the visual acuity results are not better. But if you look at this comparison, the other eyes, patients do see better if they've had basically DMEK surgery. And this has reflected the trends in transplantation globally around the world. If you look from the EBAA report, basically back in 2013, there are only 3.2% of basically cases in the USA being done with basically DMEK surgery. And this has increased over the years from 0.7 in 2011, 3.2 in 2013, up to 43% of the EK surgeries in 2019. And similarly, you look at trends based on the Australian Corneal Graft Registry, up to about 20% of cases in 2017. So you can see there's been a massive increase in the number of DMEK surgical procedures, and that's been really driven by our outcomes with visual acuity, but also the fact less rejection rates and basically improved surgical techniques, which we're going to talk about in a little bit more detail. If you look on the left-hand side, this is basically just reflecting what I've just told you. You will see that, in fact, the PK rates are actually quite stable, okay, from the Eye Bank Association in America. But you'll see the DSAEK rates over here in orange are basically falling. And you can see as this line is basically falling, it's because the DMEK rates are basically rising. And this is basically up to 2018. Now, I started doing DMEK back in 2015, and you can see, back over here, to about maybe 5-8% of my cases basically were DMEK back in 2015, and this has slowly risen over time to 2017, 2018. You can see there was a big change from DSAEK to basically DMEK in 2019. DMEK is the #1 procedure that I basically do with respect to EK surgery, and it's almost up to 85% of all the EK surgical procedures. And I'll talk a little bit about technique basically later on why this has basically shifted up to 85% as opposed to just about 20% of cases in the EBAA data. So of course I still do basically DSAEK. So where would I choose basically DSAEK? So I choose patients with DSAEK, like these examples over here, with severe corneal edema, where the view is very, very difficult. And I think even with intraoperative OCT, it would be very difficult to do these kind of cases with basically with DMEK procedure itself. And also you got to bear in mind that the stroma is going to take some time to basically clear in these examples. So here I typically basically will do DSAEK. Patients below over here, where you see the patients with eye syndromes, they've got a lot of desmoid sticking to the iris surface. they will require some sort of pupil reconstruction. You're going to get pigment release. You're going to get release of basically blood, like you see in the anterior chamber. And certainly when you're basically doing your DMEK surgery, it can affect basically having blood there with fibrin, because it can affect the adhesion of the graft or how the graft basically manipulates inside the eye. So this patient's going to need to have a pupiloplasty before we even get on to basically the EK surgery. On top, you can see the DSAEK basically going in. You can see the view is so bad, I'm having to stain it over here with membrane or trypan blue to help improve the visualization, but it's very difficult to see where the graft goes, but this will generally clear up basically as well. Children who cannot posture, like this example over here, this is an 11-year-old child. You can see had a previous PK, the graft basically then decompensated. So typically over here, we can basically do I will do a DSAEK, and you can see the reason why. I know the child has learning difficulties, so he's not going to be able to posture afterwards. So what I'll do is I will stitch the DSAEK graft to basically the host cornea itself. And I still think it's better doing an EK in this technique as opposed to basically doing a PK, because this child is only 11 years old. If you do a second time graft in these situations, of course, his risk of rejection is basically much, much higher than if you did basically an EK surgery itself. So basically you can do an EK, but you're going to have to stitch the graft, because you cannot rely on such a young child basically to posture afterwards. And likewise, you have to do a lot of anterior segment reconstruction, typically ACIOL removal. If we scleral externalize basically the lens, often I will do this as a two-step procedure, maybe do the lens bit basically first and subsequently do the EK surgery afterwards. A lot of times, depending on how it clears, I might actually basically do a DMEK in this situation instead of basically doing a DSAEK, but it depends on how good the view is basically afterwards. But generally, these are the cases where we would find that I still basically do DSAEK basically over doing primary DMEK surgery as well. So if you're starting with DMEK, which are the cases that you want to basically do? So primary procedure is basically Fuchs, that basically decompensated after cataract surgery. That'll be a good start. Maybe doing a triple procedure, so cataract surgery, and then basically a patient with Fuchs to change the endothelium. Somebody who's had a failed DSAEK, you can replace it with a DMEK. You get more experience with that. This is something you can basically start to do. Patient with PI-induced bullous keratopathy with no scarring, with not minimal decimate membrane scarring is a good case to basically start with, in which you want to basically do a DMEK procedure. And patients with less risk of basically CMV endothelitis, because you can use less postoperative steroids with a DMEK. These are also good cases in which you can do a DMEK procedure as well. Okay, so what's the barrier to adoption, or why isn't everybody basically doing DMEK? Well, there's several things that basically affect us from doing a surgical procedure. And these are really the two big areas. One, when you inject the eye inside the anterior chamber, the endothelium goes into basically a scroll. So you need to learn all these basically fancy maneuvers and these maneuvers itself on how to open up this damn endothelial graft from this basically scroll itself. You can see me tapping basically on the surface, and gently you can see the graft basically opening up. Basically, as the two wings basically open up. And remember, the endothelium is on the outside of this tissue over here. So as you're tapping on the surface, gently try to get the graft to basically open up. You have to be careful that you cannot shallow the anterior chamber basically too much, because maybe the graft will hit the endothelium, and you want it deep enough to allow the graft to open. So you need to learn all these techniques on how to basically open a graft. The second is people worry about basically the donor tissue harvesting, because you're peeling off the Descemet's membrane, as you can basically see in the video below, can be challenging. You have a risk of basically ripping the Descemet's membrane. Ideally now, a lot of eye banks, especially in the United States, and Singapore Eye Bank also basically does pre-strip basically tissue. That will save you a lot of time and a lot of anxiety as well. Because of course, if the tissue comes basically pre-stripped, typically it's on an area where there's an area that hasn't been stripped itself to allow you to basically open up the graft. But it will give you the confidence that you can just focus on trying to open up the DMEK scroll inside the anterior chamber. And it's really down to the fact that you do need some practice in basically wet labs. There is a shortage of experienced basically mentors, and this has been shown in a recent paper by Ellie Koo from Bascom Palmer, where she nicely showed that it doesn't matter how many YouTube videos that you basically watch or EK training courses. The best thing was actually having a one-to-one mentor daily, basically starting with your DMEK, doing your DMEK journey itself. DSAEK does require a microkeratome, obviously, to get around the donor issues, basically for the cutting itself. And it is possible to do basically DSAEK, but you've got to remember, if you want to get that consistent ultra thin tissue, so down in the region of about 60 microns, so basically nano thin, or less than 100 microns from ultra thin, you will get some variation with basically the cutting of the tissue itself. And you will, and initially, when DMEK basically came around, basically more 9 years ago, if you look in the literature, there were higher rates of loss of tissue from basically tissue preparation. And this is lower basically in DSAEK compared to DMEK, but the rates are basically have been falling. We now know you don't take basically tissue for people less below the age of 40 because the scrolls can be basically very tight. We avoid basically diabetics as well. There's a diabetic scale that our iBank basically uses, and a lot of the iBanks in the US basically use when they're basically retrieving tissue. So generally you try to avoid the younger tissue because you know it's going to be a tighter scroll. Avoid the diabetics because you can basically affect the issue with basically peening. But I'll just tell you that, you know, we've been doing pre-shipped tissue now for almost basically 2 years from the iBank in Singapore, and the technicians basically repair the tissue and in the first 100 cases that they've repaired, these are just iBank technicians that we taught how to basically do this stripping. They've only had one failure of the tissue preparation. So it shows you that a good iBank technician can actually really learn this, but once one person learned, they've actually taught others how to basically prepare the tissue, and we have a performer basically that we will follow. So if we think about basically DSAEK over here on the left-hand side, and we want to transition basically to DMEK over here on the right-hand side, how are we basically going to do it? Well, there's two ways basically we can do it. You can do basically what we call an endothelium out procedure, which is what I showed you when the DMEK was basically being injected inside the eye. And this involves injecting the DMEK graft. And remember, the endothelium's on the out, because typically when it scrolls, the endothelium's on the outside. And this can be done with any basically glass or plastic tube. And people have described using a modified Jones tube, Goiter make a device, DALK basically make a device, and people even use sometimes IOL injections. I've seen people use ICL, basically injectors, to put their graft in and then simply inject it inside the eye. But you've got to bear in mind that whenever you use any of these devices to inject your graft, you're basically injecting it inside the eye and the endothelium's on the outside. The second option is a slightly newer concept, I would say probably maybe over the last couple of years, where you basically use something that we call an endothelium in technique. So typically the endothelium is rolled on the inside, so when it's basically pulled inside the eye, you can use different devices. So one is boosting as a glide that you can use. We have the endoglide that I'll show you in some of the videos. Mark Morang uses an IOL cartridge. But the point is, the big difference is that the endothelium is on the inside as opposed to the outside. So when it's pulled inside the eye, and typically you need to use some forceps to bring the graft inside the eye itself, it is already in the correct anatomical position with the endothelium down. Okay, so your maneuvers are different compared to basically what you do with your DMEK when the endothelium is on the outside. And typically, if you're used to pulling a pull-through technique for your DSAEK, it's a lot easier to transition to a pull-through technique for basically your DMEK. Okay, and this is just showing you some of the big differences. On the left-hand side is the endothelium out technique. So typically after the tissue has basically been putrefied, you put it into a water bath. And once it's basically in the water bath, I'm using a goiter injector basically over here. I simply use the goiter injector, and it's basically loaded back to front. So I basically use the back end of the injector to basically, I'll stop the video on this side over here. So basically I use the back end of the injector to suck up the graft into the tube. So typically I'll use basically a 3 ml syringe or BSS. So this bath is in BSS. You can see the graft has already been stained and basically punched. I'm just gently sucking up the DMEK graft into the tube. Okay, and now it's basically ready to go. And you can see there's a syringe at the end over there. And I'll simply put another 3 ml syringe on the back. Okay, and then we're ready to basically go. So here you go. So you see the graft basically over here in the glass injector. And then we're ready to basically put it inside the eye and then deliver the graft inside the eye. So this is endothelium out basically technique. Now, endothelium in technique is slightly different, because what you need to do is to be able to fold the graft itself on the endothelium on the inside. So here I'm using some Kelman forceps, and I'm gently flipping over the DMEK tissue. So it's already been defined to the size of basically the graft that I want to basically put inside the eye. I'm gently using the Kelman forceps to simply move the DMEK over itself to make it like a trifold. Okay, so once you have this trifold over here, you're going to basically load it up into your device, either an IOL cartridge, a DMEK injector, and here you can see on the OCT where you get fluid on the surface, and here it's basically being loaded into the endoglide, and you simply grab the tissue and you put it into this cartridge itself. So the endothelium is on the inside here now, so when you put this inside the eye, anatomically, the graft is basically lying in the position where the endothelium is going to be on the endothelium down. When you set the graft into the eye, on the left-hand side, you'll see the endothelial out technique. So typically on the endothelial out technique, you see we injected it inside the eye, and then I'm using a short burst of BSS, and I'm tapping on the surface. And what I want to do is move the leaves using the water currents inside the anterior chamber to open up the graft. Okay. Now, once the graft is basically opened, I'm just manipulating the tissue across the side there. So I'm opening up all the graft using this short tapping. So I'm using the water currents inside the eye to get the placement of the graft. You can see how shallow the anterior chamber is. This is a patient with CMV endotheliitis. That's why cornea is so hazy. But once the graft is basically open, I put the gas bubble underneath the graft itself, and the graft is into position. This little marker over here is what we call an asymmetric marker, and I use that. That's my preferred choice of basically to help me with the orientation. And typically, when I make the mark, it's on the anti-clockwise surface. So when it goes inside the eye, it should be clockwise in relation to this straight line over here. And this will tell me that the graft is basically orientated correctly. You can also use S-stamp or F-stamp as basically been published. Okay, so this is an endothelium in technique on the right-hand side. Here, what you're doing is you're pulling in the graft inside the anterior chamber. So these are 27 gauge forceps, so they're very delicate forceps. So they basically will pull the DMEK basically tissue inside the eye. And basically, once you pull the DMEK inside the eye, you will see the graft will basically want to open up basically by itself, because the graft wants to open up. So the endothelium is on the outside, but the endothelium is on the inside. So here, what you do is you just make sure the graft is completely in the anterior chamber. I'm gently tapping on my incision, and you can see the graft is starting to unscroll itself. Okay, so as the graft unscrolls itself, you can see it's already basically in position, and then basically as it's basically unscrolled, okay, you can see on this side over here, the graft is almost completely open. I'm just moving it a little bit on the side. I put the bubble inside the eye, and this bit of the graft is basically opened up. Okay, so this is typically endothelium in technique. So the graft is already in the right position, and all I'm doing is pulling it inside the eye in the correct orientation, and then allowing the graft to basically open up. And that's the big difference, while on the endothelial out techniques rely on the manipulation of the graft by using basically water currents inside the eye. Okay, so how can we use basically modern technology to overcome this learning curve and help us basically get along with the surgery itself? So back in 2012, we started using intraoperative OCT. At that time, we were using this device over here. So this is a portable RTView device. And underneath that, you can see the setup that we had basically in OT. So this is about 8 years ago. And what we did was we attached this portable system to an old microscope stand over here. And you can see this over my patient's basically eye. Patients, I think, having a DALK surgery done. And you can see here that I was able to image basically the eye intraoperatively. And in this paper over here, we showed the utility of having intraoperative OCT to help you guide you with the surgery to get a deeper resection plane when you were doing DALK. And on the right-hand side over here, this is typically a DSAEK that was having with intraoperative OCT. And it allowed you to look at this interface space of fluid, and as this disappeared basically over time. So this is the recipient cornea. This is the donor cornea. This is your air bubble inside the anterior chamber. And what you can see is the spacing is basically going down. This is shown graphically in the graph over here, where the tamper, as you basically the tamponade goes with time, and this is basically 6 minutes. You can see basically the space becomes basically very minimal after we do the drainage with the venting incisions as well. And this is one of the advantages that we were able to tell intraoperatively what is basically going on with this graft. Are these basically grafts sticking, and how are they basically sticking? For DALK, we're able to help us really delineate our dissection planes. And sometimes when you're using ultrasound pachymetry devices, they're very inaccurate when you basically go below 100 microns. But using intraoperative OCT, it allowed us to basically see this in a lot more detail. Now, there were 2 studies that basically came out. One was the Discover study, and one was basically the Pioneer study. And these were basically studies that wanted to show the utility of intraoperative OCT. This is published in basically JAMA Ophthalmology back in 2015. On the left-hand side, you can see typically what I showed you previously that we published in 2012, using basically the OCT to look at the reduction in the interface basically fluid over here, or between the graft and basically the recipient tissue, where the basic arrows are. And you can see at the bottom over here, after tissue has basically been massaged and basically the fluid's been removed, you can see the graft is basically nicely opposed. So you can be much more confident then that your graft is basically opposed to the recipient tissue, and then you should basically reduce your dislocation rate. The reason why it's important to reduce your dislocation rate is that we know if you have a higher rate of dislocation, you are going to get a higher rate of basically endothelial cell loss. Now with DMEK over here, you can see what I showed you previously on the case with the crosshairs over here. You can see the crosshairs of basically the DMEK tissue. So you can see the fold over here. Now remember, the endothelium is on the outside. And this nicely shows you what I was talking about, shallowing the anterior chamber. See how close you are basically to the iris. You do really need to drop the anterior chamber down to really, really shallow to basically open up these basically DMEK grafts as well. And these 2 basically show the utility of the tissue of the intraoperative OCT basically for DALK, which we'll basically be talking about next week. Okay, here's some more ones basically with the DMEK on the right-hand side over here. So again, showing you that typical fold of the DMEK tissue. So the DMEK tissue is above the area of the graft. And you can nicely see this on the intraoperative OCT. So simply tapping in this area over here in the middle will allow these things to open up, because you're basically using the water currents to basically open up the tissue itself, okay? And this is an example of issues with recipient preparation. So remember I said with DSAEK, it's not such a big issue if you get an overlapping of your decimeter axis with a DSAEK tissue. But for DMEK, this can be a huge issue itself, because the DMEK graft won't necessarily stick where you have remnants or basically or some tags there itself. So you need to basically be careful to make sure all basically the tags are removed. And basically what these studies showed is that by using the intraoperative OCT, you actually altered the surgeon's understanding of the tissue itself, especially basically when you're doing the metal transplantation procedures in almost 48% of cases. So in one of two cases, it basically helped the surgeon providing feedback information that changed what they were basically doing at the time of surgery. So this is actually quite a lot. So you can see how much information you were getting back from the feedback from the intraoperative OCT. With respect to decision-making, from the Pioneer study, it was almost basically 38%. And the conclusion of basically both these studies is that the information gained from intraoperative OCT allows the surgeon to assess subtle differences in a unique perspective, because you're able to see this in basically cross-sectional area inside the anterior chamber. And you were getting extra information while you were operating to change your decision-making, especially when you're doing these selective tissue lamellar transplantation. So you're able to reduce your learning curve, because you were basically seeing things much better that you would otherwise you wouldn't have been basically aware of, because of course, not having the experience basically in doing the surgical technique. Okay, so I mean, we basically used this quite some time, but there were some issues with this. So I'll show you this one in the middle. So this is me basically operating back in 2011. And what you can see is that the issue with this is that you can see from here, there's no operative microscope. Okay, and the reason why there's no operative microscope in this picture is that the microscope is moved out of the way completely from the patient. So I could do the OCT, but I couldn't do the OCT and actually have the operative microscope at the same time. And we needed one technician to move this across. We needed another technician to basically do the scanning. And I'm using this foot pedal over here to move this device so I can get it in position. But somebody else had to then basically use the computer on this side over here in order to get basically the imaging. So this is one of the issues that I found basically when we were using this. But we used it for quite some time, but it is very clunky to basically use. But you have to move your actual your operating microscope well away from the operative field when you're doing it. So you can see how close this was to the edge of the operative field. You can't put a cover on here itself because it affected the imaging from the intraoperative OCT. The other microscope I used was a prototype. So this is a prototype developed in collaboration with Duke. I went there back in 2014 to do some DALK surgery. And you can see over here how big this is in relation to basically the microscope on the edge over here itself. And the issue with this is that, especially when you're doing DALK surgery, you can see how far your hands are away from basically the oculus. So your eyepieces were a long, long way away from the surgery itself. And certainly when you're doing DALK, I like to be a lot closer when you're doing your surgery itself, as opposed to being so far away. So you had a large basically working distance. And from the Pioneer study, you can see over here, again, this time this was a lot easier than basically what we had in 2011 in Singapore, where the OCT is attached to the microscope. But still, you can see over here, you couldn't look at a microscope and the OCT at the same time. You had to move the microscope away to basically have the OCT. So you couldn't get imaging of both things basically done at the same time. So what we're going to show you is basically the new ProVio 8 microscope, basically from Leica. So this is an intraoperative, basically OCT microscope. So it has the OCT built into the microscope itself. And the idea is that basically provide you information both from the operative field and the intraoperative OCT at the same time. So there are a few technical specifications, so I'm not going to go into this into a lot of detail because obviously I didn't develop the microscope, but you can get this brochure from Leica as well, telling you about the axial resolution, but your resolution is quite high. The axial resolution is about 2 to 4 microns, and your lateral resolution is about 15 to 31 microns. And so that's pretty high, especially for the anterior chamber, anterior segment, we're using a 175 millimeter objective itself. So you're getting about 30 micron resolution, which is important if you're doing basically anterior lamellar surgery, and likewise basically where you're doing DMEK or basically DSAEK surgery itself to basically look at the tissue as well. The other thing I think is important to really get an appreciation on is that how many scans and the acquisition speed. And I'll show you some of the advantages of basically having this fast scan acquisition speed when you're basically doing the surgery, because you're going to get a lot more information than you can get simply doing the crosshairs. The second thing I just want to point out for over here is that you can preset the number of scans that you want. So you can customize it up to 1,000 B scans, and it does it in almost about 10 seconds, basically, from capture itself. And I'll show you this on the next couple of basically videos as well. And it's interesting because you can image through quite dense tissue. So I'll show you basically when we're doing staining, some of the advantages of looking at through the OCT, but you can do this with, if you're a VR surgeon, through silicon oil, and also basically perfluorocarbons. And certainly if you're doing stripping under air, you can also basically see the area where you strip the dismeter rectus off as well. It has a foot switch control, so you can control the OCT basically from the foot switch as well. And one of the big advantages I see is that as opposed to just having a standard crosshair, which you have on quite a few intraoperative OCTs, it has a lot of customizable programs, okay? So you can use a rectangular program, which I don't really use that much, but the circular program I find is very, very useful because it allows you to look around all the way around the graft or all the way around the recipient when you're basically doing the surgery. And I'll show you some examples of this in the next basically couple of slides. And again, these are all quite customizable devices or scans that you can have preset as your choice basically on the intraoperative OCT basically machine. So this is an example of a patient you're going to see in a minute who's basically going to have a DMEK. So I'm going to show you some things about the donor preparation. So you showed before how we basically prepare the donor. So this is a pre-stripped tissue from our eye bank. So normally they'll basically put a hinge on the surface over here. And you can see this is simple basically crosshair. So I'm just trephining the tissue. So one of the things that people always say is that how much fluid do you put on the surface when you're doing the trephination? Because if you don't put enough fluid, then the endothelium cells are going to die. If you put too much fluid, you're going to basically go into a scroll. Okay, so it's important that you basically get this balance over here itself. And you can see in a minute on the OCT, once I basically remove this around, that you can see there'll be a meniscus line basically coming up showing you how much fluid there is inside the eye. So we're going to do a 360-degree scan so we can have a look at this in basically all the way around. And what you can see is where I've trephined, and typically you see this quite often, you can see the edge of the DMEK graft has actually gone into the trephination edge over here. Okay, so you can see that on the scan. This is the edge of the trephine. I think this is a 7.75 millimeter trephine. But my DMEK graft, because it's so thin, as I push down, it's got caught in the edge of the trephine. And we see this very, very often when we're basically doing DMEK. Okay, so this will need to be released. And you can see this all the way around. If I stop the video over here, even at this angle over here, it's slightly attached to where the edge of the trephination margin is itself. Okay, so we follow this around. Okay, so what we're going to do is I'm reducing the fluid. And what you can see here is this is the fluid line over here above the DMEK tissue. Okay, now, I can tell you when I do this clinically, I just know from experience basically how much basically fluid to be there. And if you ask me, how do you measure it? I can tell you honestly, I have no idea. I just put enough drops on that I feel the graft will not scroll. But here, you can actually see the fluid line. And you can see here that I'm covering the DMEK tissue. And that's why it's not basically going into a scroll. If you put too much in, the graft is going to scroll up. But here you can quite clearly see this is the optimal amount of basically fluid you want basically inside on top of the tissue itself to not basically get it into a scroll. Okay, now what we're going to do is I'm going to use basically an instrument, so just like a small basically spatula to go around the edge to basically free up the tissue. Okay, so here we're just using basically a spatula, so just scanning it around again. And you can see as I basically go around basically the tissue itself, you can see my instrument underneath basically the graft. There you can see it underneath the graft. So again, there you go. So you can see over here in the lower image, so you can see this is the crosshair one now. So this is green, horizontal, blue is basically vertical, and you can see over here on the vertical side where the instrument is on the microscope picture, and on this side over here you can see I'm in the right plane. I'm underneath the DMEK tissue, and all I'm doing is gently lifting up the tissue a little bit. You don't want to lift it up too much, of course, because you may basically flip it over. So I'm just lifting up to make sure it's not in the trephine basically edge around the area itself. Okay, so I'm just going around and basically lift it up, and I typically go around all the way, and you can see quite clearly how much fluid there is again inside on the tissue itself. So a little bit of fluid, not basically too much fluid, but there's enough there that I know the graft won't basically go into a scroll itself. Now, this is one of the key things when you're doing basically your staining. So I'll just go back to the bit again. So this is one of the key things when you're doing your staining of the tissue itself. It's important that you stain underneath the Descemet's membrane. If you don't stain that, you'll find that your dye basically will wash off very, very quickly. And this is very important when you're doing cases that have a lot of basically bullous keratopathy. So what I'm doing here is that I'm going underneath the Descemet's membrane and injecting this basically, this is using membrane blue to basically help with the staining, to get a deep blue stain. And again, you can see on the OCT but actually you can actually see how much fluid there is on the surface. So your OCT penetrates through the membrane blue, and I can see this line over here and this line over here on the horizontal scan over on this side, and this is basically your fluid over basically the DMEK tissue. So I've got fluid under the DMEK tissue. I know it's not going into a coil configuration, which would then make my surgery a lot more difficult, but I know there's enough fluid there that the graft is basically being covered both on the top and on the bottom. And that's important that you make sure you get a coverage of the membrane blue or the vision blue basically on both sides of the tissue. Okay, typically we will leave this for incubation for about basically a minute, and then I'll basically wash off basically the fluid from the surface. Okay, so here we go. We're washing off the fluid. So you can see there's a rise in the amount of fluid over here. So now this is the meniscal rise of level of the fluid over here on the top. So I'll show you these features again a little bit over here. So the crosshairs basically show the entrapment of my DMEK tissue in the traphium, which is actually quite common that we basically see this itself. And the circular scan allowed me to assess it all the way around in 360 degrees. And I think this is some of the advantages of basically this technology, is that you're not just seeing it in two planes. So from the crosshair, you're seeing this basically all the way around. So I know exactly all the way around where the graft is basically freed up or not. The only way of doing that as a surgeon would be to do it just by feeling as you basically put the instrument in the right plane itself. But this, on the OCT, you can actually basically see that you're in the right plane as well. Okay. Then I use basically a blunt spatula, so you can see it on this video, over on this picture over here. So it's underneath the basically the DMEK tissue to basically free up the edges, and you can see it basically on this side. And of course, again, it's important not to elevate too much, but you can elevate enough that you can free up basically the graft. And also the OCT is showing me that I'm in the correct plane under my DMEK tissue, over basically my stromal bed itself. And you can see how much fluid there is over here. Okay, so there's very shallow fluid, okay, on the surface over here. And I keep it shallow on purpose because I do not want to put too much fluid on the surface over here, because I do not want to get a tight scroll or basically go into basically a scroll configuration. If it's too little, the endothelial cells are going to die because it's going to basically become dried out. Okay. Again, now you can see that after the spatula, so now basically the DMEK edge is free. So you can see that on the OCT on this side over here. So now this is basically a free edge, and this side is basically free. So now you're ready to go on to the next stage, which is basically injecting the dye. So here we are on the crosshairs over here, and here we've injected the dye so that I can see there's nice bit of dye underneath the DMEK tissue, so you get a nice basically stain, but also dye on top of the tissue itself, but not too much fluid on the top, so that it's going to basically induce a scroll. Typically, I will use membrane blue, because especially if it's a difficult case where there's a lot of bullous keratopathy and the view is not so good, the membrane blue gives you a slightly deeper blue basically compared to the vision blue, but you can use it for whichever blue you prefer. And typically we use this basically for a minute, basically for incubation. After that, we washed out the dye. So again, you can see the fluid level rising over here. So we washed out basically the dye, and you can see there's a collapse of fluid underneath the graft. Okay, so all that fluid is gone now from underneath the basically the DMEK tissue, and we washed out basically the surface itself to make sure the surface is hydrated, because I want to wash the blue dye basically away after 1 minute. And now basically we're going to basically put the graft inside the eye. Now, what I showed you on the video was that the next bit of basically endo-in insertion is basically flipping the graft. And a lot of people ask me, how much fluid do you basically put in when you're doing the flipping of the graft itself? Because it's difficult to basically quantify this itself. So what you can see is that I'm soaking up the excess fluid on the surface. And if you watch the OCT, okay, if you watch the OCT over here, you will see how much fluid there is, and the fluid level will drop down, so it is just covering the endothelium. Okay, and this is important because, again, you need to be able to somehow ascertain how much fluid there is there. If there's too much fluid, you're not going to basically be able to make it into a trifold. If there's not enough fluid, then of course it will flip a lot easier, but of course you're going to start killing your basic endothelial cells. You can easily see over here how much is the meniscus level of the fluid on top of the graft. Okay, so once you basically have worked away some of the fluid, you can see how shallow it is now on the OCT scan on the right hand side on the crosshair. Then what we're going to do is, I'm just using basically, you can use a Kelman, or you can basically use, this is just a DMEK stripper. I'm going to lift up the endothelium, and I'm going to basically induce my trifold, basically. So you can see it being lifted up on the surface. I'm gently basically putting it on over the graft itself. And you can see here that in fact, the endothelium does not touch, because in between there is fluid. Okay, so you haven't got endothelial to endothelial touch. So this tells you this is the right amount of fluid basically over here itself, because the two parts of the endothelial leaves are not basically touching. Okay, so that's basically enough on one side. And once I've done one side, I'm going to basically do the other side as well. So again, I'm just pushing down on the top there to basically get the fold. Okay, and as I've done that itself, I lift up the other side, and you basically pull this over to induce basically the trifold from the top side. Okay, so again, you'll see that as basically the trifold is basically being formed, you gently basically pull over the graft. Stop this over here again. Sure, let's place a little bit more. There you go. So again, you can see there's fluid in between the two leaves of the Descemet's membrane. Okay, so there's fluid not only between the base leaf and the top middle leaf, but there's fluid between the top leaf and also basically the middle leaf as well. Okay, and then you're ready basically with your trifold configuration. I'm just making it a little bit neater, so you're ready to basically load this up into the basically the graft device. Okay, you can see the basically the trifold from the graft, and that's how you can basically give you an idea of how much fluid to have there and how you can basically do this scroll without basically damaging the endothelium itself. And you're getting that feedback real time from the OCT to give you some idea on how much fluid there basically should be there when you're basically doing the scrolling. Okay, then we simply take it. This is using the endoglide now. This is 23 gauge forceps that you come in to basically load the graft. Then you will grab basically the tissue. Okay, so you're grabbing basically the DMEK tissue, and I'm putting it basically inside the eye. And then we're ready to basically insert this basically inside the eye on the next slide. Okay, so this just shows you some of the videos from there itself. So this shows you the fluid line over basically the DMEK tissue, and this shows you basically how much fluid line has basically dropped down now on top of the DMEK to help you basically make that trifold into a nice neat trifold itself. And it's important to get the amount of fluid level absolutely. Now you will get that obviously with experience over time, but this is a shortcut way of actually learning how much basically fluid there has to be basically on the surface. Oops. The second one over here, we're making the trifold. So over here, you can see when I flipped over the edge of the graft over here, you can see nicely there's fluid still underneath the surface. This is on the horizontal scan, and this is basically on the vertical scan in this area over here. And now we basically have the full trifold. You can see there's BSS in between my two leaves on my trifold. So it shows you the fluid level is absolutely right, and there's no basically endothelial touch. Okay, so now we're going to basically insert this inside the eye. Okay, so this is a patient basically with Fuchs. So we have a pre-placed suture over here. This is a 2.6 millimeter incision. So you basically put it inside the graft. You can see there's a little tag there, but I checked beforehand to see, and that's actually basically a tag in the stroma. So I was basically okay with that. And simply you grab in your forceps. These are 27 gauge forceps. I'm putting in a little bit to make sure the graft will basically open up. Grab the forceps, grab the tissue again. You put it basically inside the eye. And what you'll see is that the tissue itself will basically want to open itself inside the anterior chamber. So you can see the two leaves of the DMEK tissue. We're doing the scan over here on the side. Okay, and I'm just gently tapping basically on the surface. And what you'll see is that we will basically deepen the anterior chamber. Okay, and the graft starts to open up. Okay, so to deepen the AC, you can see on the OCT on the side over here, the graft has already started to open up. I have my marker basically over here. And now we're going to basically put an air bubble inside the eye, so a small bubble of air. Okay, as you can see, the bubble of air over here underneath the basically the DMEK tissue on the side. And what we're going to do is I'm just going to basically deepen the anterior chamber now. So as we deepen the anterior chamber, you see the graft will just basically, it's going to basically open up itself. So there you go. So the AC becomes a little bit deeper. I'm just using the bubble inside the eye, and there you go. The graft basically is opened up basically by itself. Okay, so just by manipulating the anterior chamber, because I know the graft's in the correct orientation, because I can see it basically all the way around, draped over that bubble, I know basically the DMEK is basically in the right position itself. Okay, and I can follow the graft all the way around. You can see the bubble and the graft is nicely up against basically the back of the stroma. But of course, this is not the end of the case. What we now need to do is we need to put a full air tamponade. Okay, so here I've expanded the bubble inside the eye, so you need a very good tamponade basically for the graft. This is SF6 gas, basically 20%. Sometimes it will leak, but I like this 360-degree scan because it allows you to scan all the way around, and this is basically 500 scans, and sometimes we switch it to basically 1,000 scans, but it allows you to look at the tamponading effect of the DMEK against basically the back of the endothelium. Okay, you can see where it's going to stick. And this is important because this tissue is so thin, you want to make sure it's stuck basically all the way around, because graft dislocation is one of the most common complications basically following DMEK surgery itself. You can adjust the size of the scan, and normally if I do it adjusted to the size of the cornea, I normally tell the technicians to do it, make it the size of the cornea, because then you'll get a much better idea on the profile of the graft. So you can see this one is a 10.1 millimeter scan. It's quite a small eye. This is typical of the eyes that we basically do in Singapore. So typically about 10.1 millimeter, almost white to white. And you can see the graft basically is nicely in position now with the tamponade and a bit of contact lens basically on the surface. Okay, so that was shows you the advantages in quite a straightforward case. So this is a little bit more complicated case. This case was referred to me. So you can see over here on the first screen, this is a previous DSAEK inside this eye. So the surgeon had a lot of problems, and you can see there's a lot of basically PAS around the edge over here on the scan. Okay, and actually what you can see is around this side over here, there's something a bit strange going on around this edge over here from the back end of basically the DSAEK graft as well. Okay, so let's see how we're going to basically tackle this. So I'm using the OCT to give me some idea about how we're going to basically remove the graft. So first of all, we need to basically remove this old DSAEK tissue itself. So again, we scan all the way around, and you can see in certain areas around the graft, there's basically more adhesion than others. Okay, so it's not even around the whole way, and that's one of the advantages of the circular scan. You can get a little bit more information. And here you can see there's some adhesion between the iris and basically the descemet membrane of the previous DSAEK. Okay, so this is going to have to be removed because the descemet membrane is stuck basically onto the iris surface. So this is something that we're going to have to basically remove. Otherwise, the descemet membrane is going to be coming off the back end of the or it's going to come off the back end of the graft as we basically do the stripping itself. Just wait for this to basically move around. Okay. Oops, let me just load this back up again. Okay, so we just see this again. So you can see the back of the graph. You can see the adhesion there, basically between the descemet membrane. Obviously, it's a pseudophakic case. And we use a 360-degree scan to basically go all the way around. Oh, it's stuck on this bit for some reason. Okay, let me just go a little bit more forward. Okay, I'll just maybe have to just skip this through manually. Okay, so you can see the adhesion of the graft all the way around, basically on the tissue on the descemet membrane. Okay, now, okay, the oh, this video is frozen. Hang on, see if I can just load this up again. Okay, let me just come out from here for a minute. I think this file is quite a large file. Hang on, let me just come out from this program and okay, sorry. Let me just escape from here for a minute.
Yeah, thank you, Prof. Jod. We have one minute left.
Okay, let me just try to get out here. I think that the video is, I don't know, the video is crashed on that side for some reason.
Sure. So meanwhile, everyone here, if you have any questions for Professor Jod, we will take 2 questions because time is running out. So furthermore, we wanted to also share that there is a second session after today, which is actually happening next week, right? So next week at the same time, Professor Jod will be sharing on DALK surgery, which is DALK versus PK, the surgical techniques and the role of intraoperative OCT in DALK surgery. You can register for the second session over email, which we'll be sending out in a few minutes' time to your registered email address. Okay, and one more message that we can actually, from Leica Microsystems, actually have a virtual product demo. So you can sign up for a 1-hour personalized live session with our clinical experts in Switzerland. If you are interested to find out more about intraoperative OCT, as well as the ophthalmic microscope and how it can actually support you in your cornea surgery, please let us know in the post that has just been released. All right. So, Professor Jod, are you okay to go back to your presentation?
Okay, so hang on, I'm just trying to get to the right slide now.
Okay, sure.
Just give me another 2 minutes. Okay, so let's have a look here. I think that file is quite big, the one we did.
Sure, no problem.
Sorry. Can we take, is there any questions that we can take while we're just waiting for this to unfreeze?
Okay, sure.
Any questions?
We do have a few questions from the audience, and we welcome anyone to also post your questions with Prof. Jod here. The first question is, in your experience, will intraoperative OCT benefit both new and experienced cornea surgeons?
Yeah.
And,
So So that's a good question. I think that the answer is yes, because you will see that basically, as of course you can learn some of the things that I basically showed you, and that will build up over time and stuff, and you'll get an idea of how the graphs basically will behave inside the eye. But one of the issues is that that may take quite a lot of number of cases before you get a handle on being able to do the surgery itself. For more experienced surgeons, I think you're going to get you will basically be able to push the kind of cases that you're going to basically be able to do DMEK surgery, for example, and next time you'll hear about basically DALK surgery. And that will really allow you to do very much more complicated cases that you probably would otherwise have not been able to do if you didn't have the information, and it will guide you. And even if it alters your decision making once or twice during the surgery itself, that's enough to basically give you that extra information that will make your surgery a little bit easier than you would have basically otherwise have intended. And I think so it'll benefit both experienced surgeons to basically increase, because if you want to try to get to a level where currently now, I mean, DMEK is probably at best is about at a level of about 26% from the EBA data in the US, and in many parts of the world it's way lower than that. But if you want to get to a level where you're almost doing 85% of your EK surgery with using a DMEK technique, then you need to have some extra information, extra help to help you basically guide you with the surgery.
Thank you, Prof. Jod. So now, are we able to go back to
so we can go back to the slide.
Yeah.
Okay. So let's go to the there we go. Let's go to the okay. So if let me go to screen. So sharing, you can see my screen, right? Okay.
So you can
so
just
let's
full
go.
screen.
Okay. So here we go. So basically, so this is the case that you basically saw. So this is a previous DSAEK. This is quite a difficult case that you can basically consider doing basically DMEK on. And so the first thing is basically getting a good idea of basically what's happening inside the anterior chamber with the crosshairs. I think this video is not going to help me. Okay, so I'm using basically the 360-degree mode to help. No, I think it's not going to help me. No, I think this video is not going to help me. So I'll just come out of this. I'll just show you the insertion bit for this case instead, because I don't think it's going to work. Okay, let me just get out of this and then okay. So let me just show you so I removed the DSAEK tissue around the area. And then this is the insertion of the graft itself. So there's a lot of adhesions there inside the eye. So this eye is a very shallow anterior chamber because as you can see all the PAS around the area. This is a DMEK you can see on the OCT basically coming in. As I've taken out the endoglide, you can see the anterior chamber will really basically shallow down. And then what I'm doing is I'm just gently tapping basically on the surface, trying to open up my graft. And you can see the folding there inside the anterior chamber. Now my AC maintainer is running quite high here because I want to basically deepen the anterior chamber to open up the leaves of the graft itself. But when I'm gently tapping, now remember the endothelium is on the inside here, so it's well protected away from the graft. And now I can use the circular scan on the OCT, which I like quite a lot, to basically help open up the graft. Okay, there you go. So once the graft starts to basically open up, I just tap gently on the surface to try to manipulate to help me open up those folds. Okay, because you want to basically open up where you can see the folded basically tissue or the DMEK tissue on the surface. Now you can see it's opened up nicely on the OCT. So one side is basically opened up quite nicely. Now what I'm going to do is put an air bubble, and you can see when I put the air bubble in there, the DMEK goes up straight away and it deepens the anterior chamber around itself quite nicely. So now we've got the air bubble inside the eye. So the gas bubble will keep the DMEK away, and now I'm looking around to see to help me why I can't open the graft. And what I can see is that on the DMEK tissue, because of the PAS around the area, it's being prevented from opening up on that side. So I pull the graft over to one side, and then I can simply use the air bubble to tap it basically open. And there's still one area on the edge you can see on the OCT where it's not basically open. And what I'll do is I'll put a little instrument inside itself just to flick the inside edge open. There you go. So you go inside the edge. So I'm just pushing down on the iris to allow basically the DMEK tissue to basically open. Okay, now you can see the graft is nicely open inside the anterior chamber. And then I've put basically a complete air fill or a gas fill inside the eye and finish up suturing the cases itself. So a difficult case with a lot of basically PAS, but you're getting that extra information back from the OCT to help you basically with the surgery, to guide you on how to basically open up the graft. And this is at the end of the case. You see how shallow the anterior chamber is, and the DMEK graft is nicely stuck up against the back of that tissue. Okay, so just the last slide now. Get out of this thing. Okay, so I think DMEK offers significant advantages over basically DSAEK, and that's really related to the faster visual acuity results, and also, oops.
So Prof. Jod, you are now at the last slide on Singapore National Eye Center. Yep.
No, yeah. No, I just wanted to just go back to the last slide. But sorry, okay. It's not going to allow me to go. Okay.
So, Prof. Jod, so you have to go back
Yeah.
to the slides. Yeah.
Yeah. Let me just try. Okay. Let me just. Okay. There we go.
Yeah.
Okay. So let's go here. Just program to just try to calm down a little bit. So DMEK offers a significant advantage over basically DSAEK. The best rates are really at about 26% from the EBAA data as well, and it's obviously outside the US, the rates are much lower. You do get faster visual recovery, better quality of vision, and less rejection compared to DSAEK, and certainly less raised intraocular pressure. The barriers to adoption are basically related to the practice and experience, and this can be significantly shortened with intraoperative OCT. And basically you can reduce your complications and you can improve basically the outcomes from the surgery. And this is important because you will get higher rates of graft dislocation. And bearing in mind, you're dealing with very basically thin tissue inside the eye when you're doing basically your DMEK surgery itself. Okay, and obviously you're going to get used to doing that. And any extra information that can help you can reduce the manipulation inside the eye. You get 360-degree visualization, and when you get less basically dislocate, and that will basically equate to getting less dislocation post-operatively. The donor prep can be a little bit challenging. I mean, ideally, if you can get pre-strip tissue, this will help. This will reduce your endothelial cell loss, and I showed you some tips for where the OCT can basically help you. And understanding the scroll configuration in the eye can be more difficult, especially with basically with a poorer view. And this, if you get the scroll configuration correctly with the extra information, this will reduce your rate of iatrogenic primary graft failure from excessive manipulation. As far as techniques go, all endothelial out techniques do require normal anterior chamber anatomy to help you use those water currents to open up the eyes, like I basically showed. The endothelial in techniques, like I showed, allows the surgery to be performed in the presence of basically abnormal anterior chamber maintainers as well. Okay,
Yep. Okay, so that actually brings
an endothelial out.
Yeah.
Okay, so that's been the main difference in how the numbers have basically risen over that time period. And I think using technology can basically enhance your rates. So this shows you, so next week we're going to be talking about DALK, which is another challenging basically surgery that we perform a lot of as well, and how basically intraoperative OCT can help you for that time. I just want to acknowledge and thank everybody at Leica. I mean, this is the first time they basically used the microscope in OT. So I think all these guys were very patient with me, shouting at them to get the images done correctly and try to get the scans. And I think there are a lot of images options that you can do that we haven't basically even shown today, and give you basically information on how you can have these preset sizes done around the tissue, around the grafts as well, to give you an idea. But so I showed you some of the advantages of some of the circular scanning that is available with this, which I think is definitely superior if you're doing lamellar surgery compared to doing a standard, basically, crosshair imaging technique. And thank you for your attention.
Thank you so much, Prof. Jod. Okay, so remember to register for the second session next week, and we thank you so much for your time today. We'll see you again next week. Thank you.